Hi everyone, my name is Charles Davis. I'm the Chief Executive Officer for Crossroads Turning Points. We're based out of Pueblo, Colorado, but we do serve 21 counties. And so on behalf of, we have 235 employees. Um, and annually we serve about 6,000 individuals each year. And just a breakdown to give you an idea, we have about 4,700 admissions in our withdrawal management clinics. We have over 500 residential admissions a year. We also have around 300 individuals in our MAT programs. We have 3 methadone programs throughout southern Colorado, one in Lamar, one in Pueblo, as well as one in Alamosa. And so when I signed up to speak to the committee, I went back and reviewed the minutes, and I found that this committee is hitting a lot of the issues that providers like Crossroads face. And I just want to highlight some of them for you. And by the way, this is my 29th year in the field. I started as a part-time bookkeeper and didn't realize I would be in the field this long, but it's been a passion that has grown, and my former mentor really instilled in me the importance that these individuals need our services, and sometimes even when they don't know they need it. So it's up to us to make sure that they happen. What I would tell you is that the SUD, substance use disorders, it doesn't have any targeted populations. It doesn't have any people that it likes to favor, any social economic classes. We see individuals from all corners of our communities, and it'll take any opportunity it can to impact people. And so we see a wide range, everything in ethnicity, as well as income, as well as religious backgrounds. It's diverse, and so it presents a very struggle and a challenge to our clinicians to try to meet all those demands. But I think our staff do a great job. One of the areas that we've been focused on for the past 17 years is the co-occurring services, and that's mental health and substance abuse being delivered, integrated in a setting. And we saw tremendous value in that. We saw people that would get their addiction addressed, but then their mental health would kick back in. And then they would cycle, and they would bounce back and forth. And then we would work with the mental health centers, and they couldn't address their mental health issues while they were under the influence or in their addiction. And so we kind of saw this ditch happening where people weren't getting treatment from either one of us for a variety of reasons. So with the advent of the co-occurring models that came out about 1999, 2000, our former CEO really pressed us to look at it, to bring it to Colorado, and make sure that we were ahead of the curve because they were having such good outcomes. One of the places I can remember is in Memphis, Tennessee. There was a program that was doing great things. And so for 14 years, we funded co-occurring by private grants and foundations. Because we were ahead of the curve in the funding models. There's a substance abuse block grant and there's a mental health block grant. And that's how it was back then. And unfortunately, that's how it is today. Those things have not integrated. They have not come up with any rates that cover what we do. And so we still struggle to make that happen. And so we have clinicians that, again, we're billing and getting funding based on our SUD rates, even though we're providing this integrated model. And I think it's one of the areas that this committee could really help move forward and look at that. We recently added the Circle program to our menu of services. It had been discontinued a couple years ago, and we were able to revive that. The doctor that had been running it was on the verge of retiring, and we knew that if we didn't save it, it was going to be gone. And so through the help of OBH and CDHS and Signal Behavioral Health, we were able to basically resurrect it. And it's been in operation now since January of 2019, and it's having wonderful outcomes. And it's really become a staple for those individuals that have severe behavioral health issues. It's a 3.7 for those of you that know what that is. For those of you that don't know, basically it's a medical model intensive residential program that runs about 90 days. And we've had about 60 discharges, and I think we've only had 5 discharge unsuccessful out of 60. So we're having great success with it at the preliminary part. Obviously, it's more important to measure down the road, but the initial indicators are that it's a great program. I think one of the things that, and you guys just mentioned before the break, is the funding mechanisms. When I started back in the 90s, there was 3 basic models. There was a 1/12 model where we got paid just to do encounters. And then there was a fee-for-service model, which was a minor model. And then there was the line item model, which basically they gave us an amount of money. We basically told them how we were going to spend it. And then we billed based upon reimbursement of spending the dollars. And those models have all changed. They're gone. They gave us great flexibility, but at the same time, the evolution of moving to a more accountable system was inevitable. But I do miss those days because we did have a lot of flexibility on who we could help and how we could help them. There was never enough money to go around, but it did give us the ability to help folks that were in great need. And again, it wasn't based on their income or based solely on what part of the region they were in.
You have 1 minute.
1 minute? I'll make it quick. So one of the frustrating parts that I want to get to that we have is the co-occurring models rate. So I would encourage the committee to look at that. I would also look at the rural. I think I saw in the minutes you guys talked about rural versus urban, and that is a huge challenge. I think probably 14 out of the 21 counties we serve is either rural or frontier. And so we recognize that some of those counties and communities don't have the greatest number of needs, but they do have the need, and it's not always based on cost per widget if it's worth it. So that they are much more expensive to work in, but they do have legitimate needs. And so one of the advances we're working on is telehealth to help clinicians serve more areas and be more productive. And that's coming along, but it's taking a while. The only other thing I would tell the folks is the multi-tiered with Medicaid. There's these built-in cliffs that people get better up to a point, and then they've got to make a decision. Do I go off Medicaid and lose my benefits, or do I hang on? It shouldn't have to be that way. There should be a stair-step process so that if they can start helping pay, if they can start getting things done, they shouldn't run into a cliff where they just have to fall off and carry it themselves. We don't do that anywhere else. We shouldn't do that in this kind of treatment. Lastly, I just want to thank the committee from our board, from our staff. We know you guys tackled a huge task in trying to reshape the behavioral health system, and we'll do everything we can to support you.